Today I am going to present an unusual case of heart failure. So it was a 7-year-old girl from rural India with a chief complaint of progressive shortness of breath for the last 1.5 months. She had a low-grade fever for 1.5 months with a cough which was non-productive, and it was more distressing on lying down for the last 3 weeks. She was unable to lie down for the last 5 days and had a failure to thrive. With all these clinical pictures, she was admitted in a rural hospital. And she had a past history of prior hospitalization a year back for the whole body swelling starting from the lower limbs, which subsided after being treated in the district hospital. But she was not being followed up anywhere, and she was not on regular medications. She had a history of recurrent cough and cold with inadequate weight gain. The respiratory distress increased with onset of fever. There was no history of cyanosis on exertion or at rest, palpitation, joint pain, rash, prolonged fever. Other than the high-grade fever was not evidence anywhere prior to the 1 year. History of contact with tuberculosis was positive. On examination, she was conscious, alert, cooperative. Weight was 10 kg, which was less than 1 percentile. Height was also less. Even the weight by head was also very less. The pulse rate was 110 per minute, which was regular, high volume pulse, and it is high. Rate was high. The BP was low, 100 by 50, appropriate for age. The S1 was soft, S2 normal, apex beat in the 6th intercostal space, hollow systolic murmur present in the pasternal region, abdomen was soft, but umbilicus was slit-like. The liver was palpable 3 cm below the right midclavicle and was non-tender, non-pulsatile. On investigations, the blood investigation, the hemoglobin was earlier low in the previous hospital, but when it came to our hospital, it was 11.3. The total count, the CRP, all were negative. AST titer was negative. Urea, creatine, everything was normal. They had already earlier walked up for the anemia and was found to be a beta thal carrier. Serology was negative. COVID, as everybody was doing in these times, COVID was also negative. The MAN2 was only borderline positive. It was around 18/16, it was positive. But gene expert from induced sputum was negative. The chest X-ray showed a cardiomegaly with a CT ratio of around 0.7 with a full of LA, and it was a rounded contour. So the differential diagnosis which came was ventricular septal defect with aortic regurgitation, valvular AR with AS or MR, any rheumatic heart disease which was going on, or an absent pulmonary valve, or coronary cameral fistula, ruptured sinus of valsalva, AP window, or any tunnel. This child was referred to our hospital with the running diagnosis of coronary cameral fistula. So the ECG which was done was a normal sinus rhythm with no evidence of any ischemia or any hypertrophy as such. The subcostal view, as we have talked about the segmental analysis, we went for the segmental analysis, and from it we could see it was a situs solitus, levocardia, and it was a D loop with the concordance, AV concordance, RARV, and it was an inappropriate shape of the heart. So there was also VA concordance and good confluence pulmonary arteries, which we can see, and there was no defect between the aorta and the pulmonary. The aortic valve was also well functioning with normal sinus of valsalva, as the sinus of valsalva aneurysm was also in one of the DDs. This was the tricuspid and all the pasternal short axis. There is a regurgitation which could be seen in the tricuspid part. This is the suprasternal view in which a good arch of left aortic could be seen with no defect or diastolic regurgitation of diastolic reversal could be seen. So this was another view in which we can see the left-sided ventricle which is dilated, and the mitral valve is well, while there is another defect through which there is a regurgitation which is going on. There is regurgitation through the mitral valve, as well as there is another defect into which the blood was flowing. So we did an integration, and in which we get to and fro movement across it. So the paravalvular orifice, which measured around 9.6 millimeter, the aortic valve was okay, and it is, as you can see, it's a huge mass which is present just behind the LA. So what is this thing in that? It is just very close to the mitral valve. So the differential diagnosis now changed, whether it was a sinus of Valsalva, which the sinus was normal, coronary cameral fistula, as the coronaries couldn't be seen properly at this moment, left atrial pseudoaneurysm, or a submitral left ventricular aneurysm. So the huge aneurysmal sac, where is the other connection, or is it a blind sac, a congenital, or an acquired process? So for further diagnosis, we had to go for the other imaging modalities. So we chose transesophageal echocardiography along with an invasive model. T pictures are not available. So I will show you the invasive thing. We went for a CAT study, and in which the LV angiogram was done, which showed an LV which was gradually filling the cavity. The aorta was normal. The right coronary artery was fully normal. Even the left coronary system was also normal. This was a pulmonary angiogram which was done in the yellow cranial view, in which we can see the LV pulmonary arteries full. Then the veins are also normal. After the filling of the LA, the LV gets filled up, and then is the sac is getting filled up. If you closely look at it, so the filling of the cavity is from the LV. So even in the lateral position, we could see it was being filled from the left, and it is lying laterally and posteriorly. So a cardiac CT to delineate further the entire 3D model, it was shown to be a 7.5 into 5.2 dimension, which was arising from the lateral wall of the left ventricle and behind the posterior mitral leaflet. So it was a giant aneurysm arising from the paramitral region, filled by blood from the LV lying posterior and lateral to the L. So when we did a search when we searched it, we found that submitral aneurysm were found of varied etiologies. It was found that in 29 years, it was maybe a tubercular origin, or an infective origin, infective endocarditis, or post-inferior wall MI, or it can be as a result of hypertension and just as a congenital cause. This was another case in which it was suggested it was due to the raised inflammatory markers. It was found that various theories are there. Left ventricular aneurysm is found to be a congenital weakness in the posterior portion of the fibrous mitral annulus, leading to a progressive expansion of this region of the left ventricular wall. And the basic pathology is muscular between the separation of the posterior mitral annulus from the LV musculature, creating an outpouching in the LV wall. This process will distort the mitral valve and thereby the subvalvular supporting apparatus and result in restriction of the mitral leaflets and malcoaptation, resulting in significant MR. There are various types. If there is a single opening, this is type 1. If there are multiple necks, type 2, and type 3 involvement of the entire annulus. So whatever the reason, the thing is surgery. The only option which is there is surgery, and if the annulus is fully distorted, even we have to go for the mitral replacement. mitral valve replacement. But each and every case which has been reported has a very poor surgical outcome. So we went for a treatment, medical management, anti-failure drugs, calorie-rich diet, anti-tubercular medication, which was already started there on basis of suspicion, and the background, it was continued. The heart team approach was approached, the surgery was planned. So to summarize, submitral ventricular aneurysm was reported in Nigeria as the first case, and it has a racial predilection with the black Africans being mostly involved, so a genetic predisposition is thought of. It has varied presentations and etiology being congenital, genetic, infective, or inflammatory. Diagnosis is imaging with an eye to look and identify the mass. Unless you know, you will miss this thing. And treatment is surgery, of course. The outcome is poor in each and every case. Now, the difficult thing in our case was the age of presentation. It was only a 7-year child, and case for repair, and it was the failure to thrive was also there. And we are waiting for the surgery because there was significant, it was moderate MR. The surgeons are skeptical to move forward, and they are saying little more and more. The child is still surviving, and it is post 3 months of antitubercular therapy. So opinion of the members.
So it's a fairly well investigated cases. Thank you for the presentation of a very, very rare case. Now could you, with the echo itself, trace the, continuity with the sac with the ventricle?
Yes.
After the MRI, etc., you had done the angio, may not be at the outset you could put the mouth, but after all investigations are done and you know the case, could you track it?
Yes, initially also we could track the mouth in a part, but the entire thing, actually we could trace the mouth, but the other opening, whether it was present or not, that was a confusion, because there was a huge spontaneous echo-contrast inside. So even after doing a CT, when we to find out, because it was 9.6, the neck, because in the surgical outcomes, what is more difficult and poor prognosis comes is identifying the neck, because it starts with some idea, and while tying it, it comes out to be a much larger. There remains a residual leak, or it becomes very difficult to manage with the mitral valve, the posterior mitral leaflet.
No, we have understood this is a congenital submitral aneurysm. Our approach has to be either surgery or the transcatheter repair. So from transcatheter repair viewpoint, I want to find out what is the gap between the neck and the posterior part of mitral annulus.
Yes, it is there.
Samir, you wanted to say something?
Thinking the same terms as Dr. Jesse Mohan, sir, because surgery is very difficult.
I think we can close it.
Yes, we even thought of closing it with a transcatheter, but the difference, the problem was that the distance between the posterior mitral leaflet and the starting of the neck was very small. Even the PDA device or anything, if it were MFO or anything, the disc opening was not possible. If I can show you.
You know, if we have 3-4 millimeter space, that would be good enough.
No, it was not. It was only 2 millimeter. It was around 2 millimeter. We had planned. Even another thing was that in the heart team approach, which they said about, that as that it causes, if we close also, it causes distortion. It has caused a huge sac. So it was a high end flow. And if we close also, but there was already a fibrosis, and which has caused this posterior mitral leaflet traction, and that will not get resolved with a device. That CT would have better.
CT was done?
Yes, CT was done.
In CT there was a rim?
Yes, CT was there. Yes. CT, they said that it was very close to the posterior mitral leaflet.
I'll tell you the problem with surgery. The problem with surgery is that you don't have a natural seat. Natural seat is what? fibrous annulus,
Yes.
which is absent here. So you have to, where will you put the valve? So you have to create an artificial LA to LV, this thing, then you mess up with the coronary sinus, you mess up with the circumflex artery. So the largest published series from our country is from Base Hospital,
Yes.
where they did 4 surgeries for submitral aneurysms, and the results were good or bad, I don't know, 75% patient died. This was the reason, and that's the reason what sir is suggesting is that even if you can attempt, make an attempt first, because otherwise surgery is a very, and you are going to give a very undersized valve, the kid is going to grow at some point of time.
We also, you know, all of us have seen such cases. And we have been reporting, at least in my memory, for last 50 years, I am reading reports from India. The 40 years back, actually, Satyavan Sharma reported a case in American Heart Journal. We have also reported, everybody else has reported. Surgery uniformly is associated with bad results.
Yes. That is the.
And if it is actually post-tubercular, you can't even strip off the pericardium. Actually, it is such a big, huge issue when you try to dissect out. So we have to have, I think 3D remodeling is the first step I will do. A 3D remodeling will help me in planning my approach, how I am going to get into that. And I certainly feel that if I can't make a trans-aortic approach, I'll go a trans-apical approach and try to close it. And I can see if the mitral regurgitation worsens, I might think of modifying it or maybe abandoning it. But I'll definitely try to me it appears trans-apical approach for me it will be easy, but I would like to do I like to have a 3D model.
That is an.
3D reconstruction is possible, modeling being done in India easily actually. There are many companies actually which do. Let them provide a 3D model. I would actually practice, my art on the model and then probably go ahead.
Yeah, 7 years old,
Yes.
thin built.
Thin build.
Try with the transcatheter closer, whatever the surgery, the MR is going to increase in this patient. That is the main problem.
Yeah.
And
If
this
it
7-year-old
MR remains
child-
same, I'm comfortable.
Yeah, 7-year-old child, replacing the valve will be very difficult, but at the moment, and continue the patient. So this
I
is
would be
really in
happy-
the catch-in period.
I would be happy if moderate MR remains. It doesn't worsen, I'll be
Already
happy.
is having a moderate
Because
MR.
if you do surgery, the risk is very high. Surgical risk is very high. Yeah. I would, later on we can think of doing something to the mitral valve also, repair-wise. But at the moment, since there is no support to the fibrous annulus, I will try to actually close it. The best thing is do a 3D model, study it carefully.
What you can do, you, Samir and herself can sit together in some off time with all the images and try to find out. And I know that she is in need of help for the poor child. So whether 3D modeling or something that can be done in somewhere and further steps can be taken. Because it will not be very easy. I know the SSKM atmosphere to go for intervention in a 7-year-old girl. Again, you'll have to have the backup from the surgeons also. So you can sit together and decide. This is a genuinely difficult case, not the usual type. And you are thinking of some device like Amplazar or something?
Yeah, so AVP2 is one, but I'm not averse to actually using bigger coils or man-made coils actually, which can fill up this whole thing and actually seal it off. I'm not averse to that. A lot of people have experience with those big coils, which you just keep packing actually till it becomes smaller and smaller.
So that will require, I think, depending on the size of the sac, it is a quite big size. Lots of coils will be required.
Yes, but some people have made these indigenous coils, which when you release are pretty, occupy a lot of space.
Okay, thank you.
Thank you so much. Thank you. You can call this next Soma Saha.
Yes. So the next presentation will be by Dr. Soma Saha.